Okay, so yes, I'm David Hall. I'm Professor of Radiology and actually Director of Diagnostic Medical Physics for UCSD Health. I've been at UCSD for about 20 years, over 20 years now. So this morning, over the next hour, I'm going to cover MQSA, DBT, and CM, and give you a quick update from last year. So again, a lot of acronyms. By the way, it is 8 o'clock. I've got my caffeine, so I'm good. And I promise there won't be too many equations. I could give you equations in physics, but it's probably overkill. So I'll try and stick to the images and not too much equations. So the MQSA, of course, is the Mammography Quality Standards Act. FFDM, full field digital mammography, DBT, digital breast tomosynthesis, and CEM, contrast enhanced mammography. So to try and save time, I'll try and speak in acronyms rather than long-handed. Okay. So again, I always put this slide up just to kind of put it in context, and I kind of update it with the latest and greatest from, I think this is updated in October. So again, breast cancer is the most common form of cancer in women, except the skin cancers. About 30% of all new female cancers every year. Around 300,000 new cases expected in 2024. Around 40,000 deaths from that in 2024 in women. There are men as well, which adds addition to this, but of course women are the majority. The lifetime risk of breast cancer is still around 1 in 8. Again, that's an average, so there's modifiers depending on your own personal situation, depending on your personal history, whether you have the genetic markers, and there's also variation with race and ethnicity. So as we stand here, the overall risk of death from breast cancer is about 1 in 40 or 1 in 39. So that's around 2.5%. And the reason I would say that the breast imaging exists while we're here is this 5-year breast cancer survival rate, get up into the 99%, with the caveat that it's located in the breast. In other words, it hasn't metastasized, right? So you want to catch them small and early, and then the outcome's much, much better. So this slide comes from the FDA website down here. They've been publishing these numbers for a while now, and actually we've been tracking it for the last over 20 years. So if we just take a little history lesson here and go back to the turn of the century, around 5 years ago. Before that, you can see here this screen film here. The majority of mammography was being done with screen film. So I actually gave a mammography lecture to the medical residents at UCSD.
So I'm going to go through a couple of cases. Some of these are from my time in the Navy. Some of these are from UCSD. And we'll get going. So our first case here is a 42-year-old who presented with masses or lumps, both in the axilla. On the left, you can see there's a palpable marker up here, as well as in the medial right breast. There was an area of concern in the right breast that was spotted out. You can see we use BB markers at UCSD. That was from an outside facility that uses the triangles. At Navy, we would use tomo markers to reduce the artifact when we were imaging patients with a palpable complaint or pain. But we use BBs. We repeat the imaging on our patients that come to us from other facilities. Pretty much everything, especially if they're a known cancer, except possibly an MRI. If they've had an MRI, it becomes a significant issue with insurance and reimbursement and expense and time. So unless we feel that the other study was inadequate, we will not repeat the MRI. So one area of concern was spotted out here. There was a little bit of echogenic tissue seen there, and then you can see the marked abnormal lymphadenopathy. And I'll just go back to this first one in case I clicked through it too soon. You can see there's this giant bilobed lymph node on the left side only. The right side is looking normal as far as lymphadenopathy. She went on to biopsy of both of these areas. This came back just benign breast tissue, a little bit of fibrosis, and this came back metastatic triple-negative breast cancer. So with no mammographic imaging to suggest a primary within the breast, on ultrasound, our one biopsy hunch did not pan out. We went to MRI, which is the next step, and you can see our MRI over here in the MIP. There is nothing in this lady's breast. She's got this marked lymphadenopathy. This is our MIP projection, and then an axial post-contrast showing, again, that bilobed lymph node, but there are also multiple additional lymph nodes. So this is one of the often talked about but seldom seen no imaging on breast at all with metastatic disease to the axilla. And we need to figure out, is it breast cancer that's occult imaging-wise within the breast and only in the lymph nodes, or is this a different process? Okay, so we have the positive breast cancer diagnosis from the axillary node biopsy, so that piece has been solved, but only about 0.3% of the MLOs will show enlarged nodes that prove to be cancer. We see enlarged nodes all the time: flu shot, COVID shot, cat scratch, you name it. There's a bazillion causes of it, but very, very uncommonly is it actually cancer. And even more uncommonly, will you not see it on breast MR? Up to 86% of the time, so 50 to 86% of the time, you'll find it on breast MR, and that's why we go to it.
So we're going to switch gears a little bit. We're going to talk about the evaluation of the male breast. A couple of things that we want to review this morning is understanding how we image the male breast, which is going to be very similar how we do imaging of women. I'm going to focus a little bit on gynecomastia because it's actually, there's some details that are important to know specifically for management. And then we talked on the first afternoon of the course a little bit about male breast cancer, and I'm going to delve into that a little bit more and review the imaging appearance and incidence of male breast cancer. So if you do breast imaging, you'll see male breast patients several times a week in your practice. So it's not uncommon to see male patients. The good news is that most of the time is going to be benign findings, and the most common benign finding that we're going to encounter is the gynecomastia. However, we do see male breast cancer. I was reflecting on Dr. Viselli's comment that this year so far she has seen 3 cases of male breast cancer. And that happened to me once before, and I thought, oh my God, what's going on in the world? We'll see 1 per year, sometimes we'll see 2, and then every time we get to see 3, it's like, oh gosh, what's going on? So then I have to remember, we're also a tertiary care facility, so we get referrals of these patients, but it really is not common to see 3 male breast cancers a year. I'll talk more about male breast cancer in detail in a little bit. I had to shorten this talk a little bit, but there's the ACR appropriateness criteria, and they have different variants. There's a specific one for imaging of the male breast. You can find this variants in the ACR website, and you can access those. They have a series of procedures and tell you which ones are appropriate or not appropriate. And I wanted to include this one because any male breast patient that comes in with a clinical diagnosis of gynecomastia should really not have imaging, right? So that's in our appropriateness criteria, but we see them every week, multiple times a week. So what we need to understand is that it's a common process, male gynecomastia.